People are starting to join, see? So I'm gonna give them another minute or two. I'll switch over to the other computer. Like a monitor, and then you can have this one to kind of move the slides. Okay. So good afternoon, everyone. Thank you for joining. My name is Dr. Wanda Montalvo, and I'm the Executive Director for Jonas Nursing and Veteran Healthcare. I want to thank you for joining us and letting you know that this is a joint collaboration between Jonas Nursing and Veteran Healthcare and Vision, Jonas Vision,
Children's Vision.
Children's Vision. And we're really pleased to have Dr. Stephen Brooks. I just wanted to take a quick moment to encourage people to tweet the information that you might be hearing today at Jonas Impact. I'm recording the session and hope to make it available later on. Anyone who has participated, I will be providing the slides at the end. And then we'll kind of move forward from there. I also wanted to just quickly say that I want to acknowledge Francis Peterson Burke, who is the person who's a Jonas Scholar, Jonas Hoffman Scholar, who is interested in helping to promote education among nurses pursuing doctoral education to know more about vision health. And part of her work is looking at, let's see, make sure I have this right. She's doing research on age-related macular degeneration. And so she provided us with several topics, and Dr. Brooks looked at the list and selected this topic for today. So thanks for joining. If you have questions, please submit them via chat. And I think you could rock and roll from here.
Okay, thank you. Good to be here in virtual space. Okay, so advancing.
Should go down.
Downward.
Not going. Was working just a little longer before we did this. There it goes. It's just a delay.
Is it just page up, page down?
Yeah, page up, page down.
Okay. All right. It's not going to auto advance now, is it?
No.
So the subject was originally going to be focused on systemic disease in the eye and conditions that included issues that might affect the vision. But then when I was thinking about it in the audience, I thought maybe it would even be better to take a step back from that and talk about just how to evaluate the eyes and then include some information about particular conditions where that's going to be most important. And I was under the assumption, and usually right with a more primary care oriented audience, that you don't have a strong background in ophthalmology. It's usually just a survey at best. So I hope this is helpful. And you can look at a lot of eyeballs and eye conditions and really have no idea what you're looking at. It can be confusing. So it's not what you look at, it's like Thoreau said, it's what you see. And hopefully we can clarify some of these things and make it a little easier to understand when you have to consider either an eye problem or a visual complaint. And it can be complicated because the eyes can be affected by literally thousands of different pathological processes, including metabolic conditions, infections, tumors, degenerative conditions, inborn errors, all sorts of things. Sometimes the conditions are truly isolated to the eye, and that's the only organ you have to worry about. And other times they're manifestations of something larger and part of a systemic disease or multi-system problem. So some examples of conditions that are truly isolated to the eye would be like pink eye conjunctivitis, or styes or chalasia of the eyelids, trauma or abrasions of the cornea, cataracts, color blindness, astigmatism. Not really very many systemic implications there. Things that might appear isolated, like some bleeding inside the eye, or something as maybe as innocuous as just blurry vision, or an irregular pupil, a cataract in a child with Chavin's, they can seem isolated, meaning it's not obvious that there's other things going on, but under the surface there can be very serious systemic implications outside the eye. So they just need to be the tip of the iceberg. Then there are things that are definitely not isolated, and those include manifestations of known systemic conditions like diabetic retinopathy or complications of Graves' disease, a lot of rheumatic conditions, manifest with inflammation inside the eye. So there's a lot of things that are clearly not isolated and require us to take a deeper look at the patient as a whole. So my first recommendation for anyone looking and having to evaluate an ophthalmic complaint is try to define it very clearly. If someone says, I'm not seeing well, maybe you want to ask things like, are you seeing double? Is it blurry? Is it something new or long-standing? Has it been around for a while and stable? Is it progressive? You really kind of want to narrow down the complaint, and that's going to help dramatically in narrowing down possibilities. Things like, my eye bothers me. Okay, well, is that pain, itching, pressure? Sometimes it's just one eye. People say, I'm having trouble reading. And they say, well, have you covered one eye or the other? Could it be one or both? Is it specific only to one particular activity? And also, is anything else bothering you? So is it associated with it? And when they come to me, they're often giving me the ocular symptoms. Maybe when you'll see them, they may provide other things. So I have to ask about these other things. They're not as second nature to me as it might be in a primary care environment. So here's one example. A 45-year-old who, and this is a common complaint, my eyes hurt. That doesn't tell you very much. Could be something very simple, could be something severe. So the complaint's vague, and it's important to get some more context here. If you question about when this occurs, she'd tell you that she works at a computer all day and the discomfort is late in the day. That kind of puts it in a benign category where it could have been pain, redness, loss of vision. This is like the eye strain or presbyopia, which almost everyone gets in their 40s or early 50s, and often complicated by some dryness as well, especially in females.
I think you just diagnosed me.
Yeah. I diagnosed myself with that about 10 years ago, so I've lived through it. Here's another example. A 5-year-old who complains of seeing spots in their vision. You might think this is not too common, and it might be kind of an alarming thing. Why is a 5-year-old telling me something like this? Well, is this floaters? Is this something inside the eye that the child's seeing, like blood or inflammatory debris? Do kids even get that kind of stuff? Could it be a sequelae of a migraine? Are they bright spots, dark spots? So most commonly in this scenario, you'll find, and I've just found this over the years, that the kids are seeing multicolored spots that come and go randomly. They're not bothered by it, and vision is not affected. So when we get a little more context, it's not really something that's coming up as physiologic and there are no worries. It might even be that these kids are seeing, maybe they looked at a light, or they're seeing, or they rub their eyes. You know how sometimes you get the sense of colors and spots appearing in your vision. Sometimes they're just noticing these things for the first time that we don't really even think about. But seeing spots in your vision is a red flag for a parent. And if you don't have perspective on it, it can get you kind of worried. And then finally, a 70-year-old who complains about double vision. Now that can be potentially serious. That makes me think about things like brain tumors, strokes, myasthenia gravis, all kinds of serious things. So you really need to get some more information. Double vision is a serious complaint, especially when it's new onset. But further questioning, and this is important, is that the double vision goes away when the left eye is covered, but not when the right eye is covered. So the left eye alone is seeing double. If you cover that eye, no problem. So this is a case of monocular double vision, not binocular double vision. And that suggests an optical problem, like an early cataract, which is not too serious. This patient does not have to go that night to an emergency room and get a CT scan. And really, if you did that kind of questioning, even in a primary care setting, you can be entirely reassured that a stat ophthalmology consult isn't required either. So those were just a few questions, maybe an understanding of the nature of the double vision can help sort things out. So there's a lot of different levels where vision can be compromised. So when you are faced with thinking about what's the source of the visual complaint or the visual disturbance, here are the things that you need to consider kind of in order front to back. First is the tear film, which is actually the layer of tear fluid on the front of the cornea that acts as a refractive surface. So people with dry eyes, either through an aging process or through the use of medications or sometimes disease, like Sjogren's syndrome, have a poor tear film. And so it's almost like looking through a windshield where there's a little bit of debris on the surface and you can't really wipe it away. So tear film abnormalities are very common causes for blurry vision, and that kind of comes and goes. Then beneath that, there's the cornea. That's the clear tissue at the front of the eye that further refracts the light to get it focused on the back of the eye. And the cornea can be affected by all kinds of pathologies, and that's usually something that's quite visible to you if it's like a scar or an infection, because it's right there up front and you can see it with your naked eye. And then we have the lens. Moving further back, light travels through the crystalline lens of the eye, and when that lens loses transparency, as it does with cataract, vision can be compromised. And then you have the vitreous gel. That's the large, sort of semi-fluid, gelatinous space in the middle of the eyeball. It occupies about 4/5 of the eye's fluid content, and that can be a source of visual disability if it gets filled with, for instance, blood or inflammatory debris, and it's where floaters are. So naturally, through the aging process and especially through if you're myopic or nearsighted, you tend to develop these little strands of protein that float around in that gel, and when the light catches them right, you see the shadow, and that's a floater. And most of those are benign, but new onset floaters and ones that come up suddenly, especially large amounts of them, that can be suggestive of bleeding. So a hemorrhage in the eye or a tear in the retina where tissue is released. And then we have the retina, and the central part of the retina is the macula, and that's where we get our central vision, where we process our central visual acuity for things like reading and seeing details. So when the macula is damaged through a number of processes, there's a loss of central vision. So if people are telling you they're having trouble reading, it's not the peripheral retina that's involved. If it's going to be something retinal, it's going to be in the center, in the macula. And one of the most common things that we see clinically in adults would be diabetes affecting the macula or macular degeneration. And then there's the optic nerve. So the visual images that are formed on the retina have to be transmitted back to the brain, and they go through the optic nerve. So lesions or pathologies affecting the optic nerve also can affect vision. So you can see there was about 7 different layers to think about in terms of where the primary problem is for someone complaining of vision loss. Just to go over the terminology, because this comes up a lot and it's common. People who are nearsighted, that we call myopia. So myopia and nearsightedness are synonymous. And in an eye that's nearsighted, the optics of the eye are so strong that the light is brought to focus in front of the retina, which makes it fine for objects that are close up, but very blurry for things that are far away. That's what the majority of kids needing their first glasses are. On the other side, when the lenses are not strong enough to bring light into focus on the retina, but instead do so at a point behind the eye, we call that hyperopia. It's also called farsightedness, but it doesn't imply that people can necessarily see far away. You can be hyperopic enough that you really can't see at any distance, but it's optically harder to see close up than far away in hyperopia, but it doesn't imply you can see up close. So it's a little bit of a misnomer. But if you think in terms of the optics, at least you'll conceptually understand what the term means. And then astigmatism, which can occur by itself or with either of those 2 other conditions, is when the light rays are brought to different points of focus and not all coming to a simultaneous point. So hearing that someone has decreased vision or has a complaint about vision without further information is really not very specific. The next step after you've gotten some perspective and asked some questions and been thinking, having kind of going through your mind where you think the problem might be, is to conduct a basic eye examination, an examination of vision. And I don't mean that you have to invest in lots of technology like we have in our office, or spend a few years in specialty training. There's some basic things here, and these are elements that I'll discuss. Maybe it's good to start at what is visual acuity, and what does it mean to be 20/20? If I say you're 20/20, what is that? What am I really saying there? What I'm saying in optical terms is that your eye is good enough with glasses, or if you need a correction at all, to see letters that are so small that each segment of them subtends only 1 minute of arc, which is 1/60th of a degree. Okay, and so a 20/20E would subtend a total angle of 5 minutes. Each of those bars, the dark, light, dark, light, dark, is 1 minute for a total of 5 minutes. And you can scale that so you can have a 20/20E that's very small if you're testing it close to the eye, but then it has to scale up and get bigger as you get further away from the eye. So that's how eye charts can be scaled according to the testing distance that's recommended. Another way to think of it is that at 20 feet, you can see, and this is just general term because most people with normal corrected vision are 20/20, that at 20 feet you can see the small size letters that you should be able to see at 20 feet. But that's a real lay definition, okay? This is the more precise definition. So a 2200 letter is 10 times the size of a 20/20 letter. So if you're 2200, that means at 20 feet testing, you can only see a letter 10 times the size of the 20/20 letter. You can't get anything smaller than that. That's not good. That's legally blind. That's what I am without my glasses.
I think I'm in that category.
So to get an idea of what these letters might look like, if I were to take a picture of them on your retina after your eye has focused them, this is a 2400 size E, drawn more or less to scale on the retina. So that's 20 times larger than a 20/20E. So you can see that big E at the top of the chart. That's how much space it takes up on your retina. Now look what a 20/20E is.
Oh, wow.
It's tiny. Okay, so, and that's the only part of your retina that has photoreceptors packed tightly enough to actually resolve, has enough pixels in it to resolve that tiny little letter. If I were to take that little letter and project it somewhere else in the retina, you wouldn't be able to see it. That's why damage to your macula is so devastating in terms of being able to see small letters and to continue reading. That's central vision. Now, testing peripheral vision, you do kind of in a confrontation manner by holding, having a patient look at you while you hold up objects to the side and ask them to identify when your finger moves or how many fingers you're holding up without them looking at them. So you can test different quadrants that way. It's called confrontation visual field testing. And our visual field is separated into a nasal half and a temporal half. So the nasal visual field for an eye are the things that are present from the center of your vision out toward your nose, and the temporal side are from objects that are presented from the center of your vision out toward your ear. So they project to opposite sides of the retina. So your lateral retina is what's really picking up your nasal visual field, okay? And your nasal retina is picking up your temporal visual field. And the midline between them is right through your fovea. So peripheral vision deficits in general, if someone is unable to see, let's say, objects to their left with each eye, so it's binocular, that usually implies a problem in the brain because the nasal visual field and the temporal visual field in the fellow eye kind of come together in the brain. So the right side of your visual field projects to the left side of your brain, and the left side of your visual field projects to the right side of your brain. So things get crossed when the two eyes have to merge together. Deficits that are present in only one eye, peripherally, but not the other eye, are not due to neurological problems. There's something in the eye, because anything neurologic is going to affect both visual fields symmetrically. But if you have something in your eye, like a retinal detachment, or a scar, or even an optic nerve issue on that side, any deficit's only going to be localized to that one eye. So that's why when you test peripheral vision, you want to see if the defects match up or if they're truly one-sided. That really changes the game completely if they're binocular versus monocular. Okay, we'll move on to pupils, because they're important. They're kind of easy to test. They're not really that confusing, and they can be strong indicators sometimes of serious conditions. And pupils have two sides to them. Number one is the efferent side, which is the nerves that control their constriction. So the motor side of things. So when they constrict to light or to reading and they get smaller, that's the motor side. That's your third cranial nerve. The afferent side is the visual inputs that then feed back to change your pupil size. So like when you shine light into an eye and the pupil constricts, the light impulse is giving you the afferent signal going through the optic nerve, and then your third nerve is giving you the efferent signal back to the eye to tell the pupil to constrict. And the pupils are usually symmetric in size, shape, and reactivity. So here's an example of asymmetric pupils. And what do you notice here? There's a couple things. One is that the right pupil is larger than the left. And then the other thing that's not symmetric here is the lids. So the left lid is a little droopy. So you have a smaller pupil and a droopy lid. So which pupil do you think is abnormal? It would be really hard to tell if the right pupil was pathologically dilated or the other pupil was pathologically smaller. But you got two abnormalities on one side. That tends to point to the left side being the abnormal one. And this is an example of what we call a Horner syndrome, where the sympathetic nerves, which are part of the motor system to the pupil, are inhibited, and it results in a smaller pupil and a ptotic lid. And there's additional pharmacologic testing and sometimes neuroimaging that's needed here.
Can I ask you a question? And a person who has, what you just showed, would there be problems for them to kind of get around mobility? Would they be not able to kind of locate things in their space, so to speak? Because this looks like an older person, and I'm thinking about safety.
No, this doesn't really have implications that way.
Okay.
Pupil size in general isn't going to affect your visual functioning. So you have a small pupil or a large pupil, and people's pupils vary in size, and sometimes medications affect it.
Okay.
But they don't really affect your mobility. The implication here, though, is sometimes the pupils are a sign of more serious underlying things. So someone with a Horner syndrome like this, for instance, is going to end up getting imaging to rule out a tumor somewhere along the sympathetic chain or a stroke. But in and of itself, the pupils are not a big deal. Extraocular movements, however, can affect mobility. So I'll show you some examples here. And when you look at the extraocular movement, we're talking about how well each eye moves independently, so the range of movement up, down, side to side, and also how well the two eyes move symmetrically. Because ideally, you really need for your vision to be normal, both eyes to move symmetrically. And that requires the coordinated function of 6 extraocular muscles per eye. So the 4 of them are controlled by the third cranial nerve, superior and inferior rectus, medial rectus, and the inferior oblique. 1 of them is controlled by the sixth cranial nerve, that's the lateral rectus, and 1 by the 4th cranial nerve. So extraocular movement is controlled by the 3rd, 4th, and 6th cranial nerves. And then you have basically mirror images on each side, and you need all the muscle pairs to be kind of symmetrically innervated for your eyes to move together. Very complicated system. If the eyes are inappropriately crossed, we call that esotropia. So you can see here in this cartoon that the left eye seems to be kind of deviated inward and the right eye is looking straight ahead. And you can tell by the position of the little light reflex on the cornea how it's decentered in the left eye off to the lateral side a little bit. They're not symmetric. So asymmetry of the light reflexes is a decent indicator of eye alignment. On the other hand, if the eye is deviated laterally, that's called exotropia. And you can see the corneal light reflexes on the other side of the pupil compared to what was here. Esotropia, exotropia. You can also have a hypertropia, where one eye is inappropriately misaligned above the other eye, and the light reflex is down below the pupil. And if it's the opposite below, it's called a hypotropia, and the light reflex is moved to the top of the pupil, or top of the cornea. And let me also point out, OS, left eye, and then the right eye we abbreviate as OD. See that a lot with ophthalmology. OS is left, OD is right. A test that I would recommend if you see patients, you involve the examination of patients, is called the Bruckner test. It's a really useful test, particularly in children. And all it does is involves the use of a direct ophthalmoscope, and you just shine the light from a direct ophthalmoscope at maybe a 4-foot distance from the patient, trying to illuminate both eyes simultaneously and look at the red reflex. And what's normal is when that red reflex is highly symmetric and a nice kind of dark red or orange without a lot of variation around the pupil. And you see the corneal light reflexes are centered. That tells you normal alignment, good symmetry, clear media. You get a lot of information there. Child with esotropia, you can see the corneal light reflex is deviated laterally in the left eye here. And also you can see that the strabismus, the esotropia, doesn't allow that red reflex to be as dark as it should be. It's kind of brighter. So there's an asymmetry of brightness and also a decentration of the light reflex. Very easy test to do. I mean, you haven't had to ask the child anything. It's a non-threatening test. If you see something like this, where there's good symmetry, but it's not uniform dark, it's like the dark area in these eyes is only at the bottom of the pupil, and then there's bright crescents up at the top, that's indicative of an optical problem, in this case, hyperopia. On the other hand, if the patient is myopic or nearsighted, you see the bright crescent at the bottom of the pupil. And here's an example where you have bilateral myopia, which is worse in one eye than the other, and probably also left esotropia. So you can really assess all of those things with just one quick look with your direct ophthalmoscope. That's the Bruckner test. Totally useful. It's also important in assessing alignment to consider the possibility that the eyes may be aligned in one position, but not in others. So here's someone who's lost the ability to move the right eye laterally through an injury. They look great straight ahead. You wouldn't think there was a problem here. They look great looking to the left. Now you ask them to look to the right, and this is what you get. The left eye has no problem doing it. The right eye can't do it, just stays in the center. And it's amazing how often a patient will think the left eye has the problem. It's doing all this movement. But that's normal movement. It's the lack of movement in the right eye that's abnormal. Here's someone who's lost the ability to move the left eye upward. So in this photo, you have a right hypertropia or a left hypotropia. Okay? And what other sign do you see here that might indicate what's going on? Big bruise.
Mm-hmm.
So this person had an injury and had a fracture
Mm-hmm.
of the orbital floor, and the inferior rectus muscle has been caught up in that, and it's kind of tethering the eye down and preventing it from looking up, and this is called muscle entrapment. And here's a patient who looks to the left, and the right eye goes zooming up into the corner. That shouldn't be happening. She's asymptomatic, doesn't have any double vision, didn't really even know she had it, has to tilt her head a little bit. This is a weakness of the right superior oblique, congenital right superior oblique palsy, and that causes the eye to become out of sync with the fellow eye when this patient looks to the left. If it was a left superior oblique palsy, you'd see this kind of situation, but of the left eye looking to the right. Here's a child that's walking around habitually with her chin elevated, and the parents weren't really sure why she was doing that. They thought it was more of a behavioral issue. Mm. But look what happens when you force her to a primary position.
Oh, wow.
So she has an inability to elevate that right eye. When she tries to elevate the right eye, it only goes up to the midline, and look how much further the left eye goes. So here the left eye is actually the normal eye. It's moving fully. She's attempting to look up, but she can't get that right eye to elevate. So she just walks around with both eyes kind of pointed down and her chin up. And these are all things that we see on a fairly regular basis in the pediatric ophthalmology clinic. And then finally,
can I ask you a question on the case that you just showed before? Like if she was in pre-K and all that, like, you know, nobody else noticed that she was, or is that why they finally presented?
She presented, I know, fairly late.
Yeah.
I forget exactly what brought her in. Probably someone finally said it's just time to get her eyes checked. Mm-hmm. The chin-up posture can mask things, and if it's a long-standing thing, particularly if it's congenital, the kids don't complain because they don't really even know it's abnormal. Okay. I mean, they're born with it, yeah, so exactly. They're dealing with it, and they just think it's a habit. You know, she has a habit of doing this. Okay. They don't think much of it, especially the lack of complaints. Mm-hmm. And in pediatric ophthalmology, the lack of complaints really means nothing because they don't complain. Mm-hmm. Okay. So you can never really rely on that. And then finally, you want to be able to examine the eyelids and the orbits. Then you kind of have everything more or less surveyed. And the lids with things like drooping or retraction in lid position or proptosis. So here's a baby I saw recently with a droopy left eyelid from birth, and this is called congenital ptosis. What do you see here? Doesn't really look that abnormal.
Well, there's redness in the left.
There's a little bit of redness in the left, and if you look at it, you see the sclera showing above the lower eyelid on the left. That's not normal. And the lids, look, you just see more of the lids, and the eye looks maybe pushed down slightly and pushed out. Mm-hmm. So this is a patient who has proptosis, which means forward movement of the eye, and it's caused it to bulge out a little bit between the lids. And whatever's causing it to bulge out might be making it a little red, plus it's harder to blink when that happens, so your eye can get dry and irritated. So this could be something like Graves' disease. There could be a tumor behind the eye. It could be a lot of different things, but it's never normal. There's always going to be some pathology, but it certainly directs you to look somewhere behind the eye on this. And then we have the anterior segment. So looking at the cornea in the front of the eye, the easiest thing is just to use a pen light and an ophthalmoscope.
I have one question. Can you elaborate on what may have caused the ptosis on the child in the previous slide?
Most of the time when children in this age group, in infancy, show up with ptosis, it's a congenital birth defect involving the eyelid muscle on that side, and it's isolated. It's not really part of a syndrome. When it's acquired, on the other hand, let's say the child was born, both eyes were normal, and then later on in life, as a 3-year-old or a 4-year-old came in with ptosis, then you're starting, that's a red flag. Then you're starting to think of more serious processes like a Horner syndrome, some neurological problem, or some infiltrated problem behind the eye that's affecting the eyelid's ability to elevate. So in infancy, it's usually benign and just a lack of proper development of the eyelid muscle. And it's almost always a surgical problem.
Okay.
So this is, in fact, I'm pretty sure the child's in the pre-op area, looks like he's wearing a little surgical gown there, about to go back and get that fixed. So we have to elevate that because it prevents the kids from developing normal vision. They get amblyopia very quickly, which could be a great subject for another talk. It's pediatric vision issues, but usually in this age group, it's a congenital error in development of the lid. So here's some examples of things that are fairly easy to see just by direct inspection with a pen light, or corneal, there's like corneal scars. These are examples of cataract, and this one on in this eye is a pediatric cataract. Kind of has a really cool appearance in the center of the lens. It's opacified with these little spikes going over each side, and you may not see this with a pen light, but you're not going to miss it with a direct ophthalmoscope looking at the red reflex. And if you don't dilate the pupil, you won't get this nice red reflex around it, but you will see the opacity. You can see how much light is getting back through this, not very much. So this is something you will detect easily with a direct ophthalmoscope, but not a pen light. This cataract, on the other hand, causes kind of a white pupil. You're certainly going to see it with a direct ophthalmoscope, and you will probably also see it with a pen light, because you're going to see a white appearance behind the pupil, and that's not normal. We have conjunctivitis. These are things you're going to see a lot. Conjunctivitis, where there's injection and dilation of the blood vessels over the eye, over the sclera. Sometimes there's going to be some drainage and exudate. If there's an infection, this can be viral, it can be bacterial, it can be allergic, it can be toxic. Or you can get something that looks far worse, that almost looks nodular here, with a dense redness over it. That's when the actual sclera, the actual white tissue of the eye, is infiltrated with inflammatory tissue. So conjunctivitis is kind of a dime a dozen. Everyone involved in any healthcare is going to see that. This is much less common, but this has much more serious systemic manifestations, and many of these patients will have serious underlying pathology like vasculitis or sarcoidosis or other things that can be potentially life-threatening. So if something is looking extremely bulky and painful, try not to misdiagnose it as conjunctivitis, because this needs urgent attention. This is usually going to get better on its own. And finally, optic nerve and retina. I've given you examples of pathologies, not really thinking that it's going to be particularly easy for you to visualize these, even looking through the pupil with an ophthalmoscope. But here's an example of diabetic retinopathy with multiple hemorrhages in the retina and in front of the retina. Here's a swollen optic nerve from raised intracranial pressure. This is papilledema. And here's a vitreous hemorrhage. And this might have been from trauma, diabetes, sickle cell disease. Occasionally, you can even get them from severe coughing or Valsalva. So after you've been able to ask questions and do a basic eye exam, it's important to try to communicate your findings with other providers. If you're going to co-manage a patient. So knowing the relevant anatomy of the eye is important. I didn't really go over that because I didn't think we would have time to get into that detail, but try to get a basic understanding of ocular anatomy and relevant terminology. And I would say if you're going to be involved on the front line of care, always have a few go-to ophthalmic consultants you can call on anytime. Someone you can text or email easily. It makes life much, much easier in co-management. And finally, have an awareness of certain conditions which may be relatively common, that almost always have some ocular manifestations, and patients require an ophthalmologist to be on the team and probably examining them periodically. So things like diabetes, Graves' disease, lupus, sarcoid, and then genetic things like neurofibromatosis or Down syndrome. There's a lot more. There's lots of these, but these are big ones, and these ones are ones I think you'll encounter with some frequency. Okay, that's all I have. Happy to take questions. I hope it wasn't confusing, maybe illuminating.
Just trying to unmute folks in case they have any questions, or they could submit questions via chat, because I'm not sure how much more background noise I might get if I unmute folks as I'm recording.
Okay.
I will say that it was through an ophthalmology exam that one of my girlfriends got diagnosed with MS.
Yeah, yeah.
So it's amazing. It was, you know, she was complaining, and it was the provider during the exam that actually diagnosed her many years ago. And so caught it early enough where she was able to get support. Her disease has progressed, but it was through an eye exam.
Yep, MS often has a presentation with the eyes, either as optic neuritis or nystagmus. We've also diagnosed tumors that way, sarcoid, I mean, you name it. Sometimes people have chronic problems with a condition, but they won't necessarily be seeking care because it's not so bad or some achiness. But when the vision starts to go, that kind of gets them in, and then all of a sudden it's all making sense. But that MS friend, that may have been literally her first manifestation.
It was, yeah. They caught it really early for her. So there's some, let me get this, because I have some additional resources that are available to folks. I want to thank Prevent Blindness for sharing these additional slides and resources. I always, as someone who's worked in community health, I feel that it's always important to provide people with resources that have been vetted, evidence-based, and available to them, because, you know, we're all busy, but we also, depending upon where people are in the country, we may or may not have access to some of the specialty providers, such as ophthalmology. So it's important for us to use our networks and use resources to help provide education, empower our patients when they get diagnosed with vision, eye health. And also, I'm seeing chat questions come in, so just pose a question, sorry. This is a statement from Frankie. She says, thank you for this talk. This was extremely informative. One thing that I often used to run into in practice was this idea of fatalism. A patient would say something like, oh, I'm old and vision problems are inevitable. How can nurses best empower patients to take ophthalmic problems seriously and encourage them to take action?
I think that's common. I certainly am guilty of that with my own health sometimes, just feeling like I'm falling apart and why bother. But for patients who are really 50 and over, I think an annual eye exam just has to become part of their routine health care. And if they and their ophthalmologist are in agreement that a problem is not so serious and just long-term aging, then so be it. But ignoring things, especially things like glaucoma, cataract, macular degeneration, can be such a big mistake. And I think empowering people might be as much as putting them in touch with a provider who they can have good chemistry with, but also saying, listen, being blind is no fun, especially if it's preventable. And you can't make everyone get engaged, but trying is the best we can do.
I mean, I would think, you know, something as simple as putting a blindfold on them and just letting them experience that for 5 minutes might be enough to encourage them to get support. And, you know, it's just so, you know, having them watch maybe videos of someone who is blind and what life is like might be one. But usually it's because they're more scared of finding out that there is something wrong. And what do you do with that, right? So it depends. It's always about the conversation and building that trust for them to kind of obtain support. So I just wanted to provide resources that are available to folks from Prevent Blindness. They have incredible tools on patient education. They're all available online. Fact sheets, risk assessments, financial assistance for eye exams and glasses. And sometimes maybe people may not want to pursue additional, information around their eye health because these are real things, right? Financial things might be the things that are scaring them from pursuing additional, screenings. And just knowing that there are resources available to them is important. Patient empowerment, living well with low vision. Again, Prevent Blindness has these great resources for people that live in various communities to help provide support and understanding. And I think one of the other things is being able to kind of find a community where other people are having this lived experience and letting them know that they're not alone. I love the resources that they have. There's a patient story portal there that folks can access. And going back to the question that Frankie put up, this might be a tool that you could use in your back pocket. Having these type of resources available to you when you're speaking to your patients is another way for people to know that there's information out there, and they can kind of relate to some of the stories that are available to them. Being able to be, advocates and support for making sure that there's legislation in place that support, overall eye health for people. We have a growing number of aging population in this country, and in many ways we have to kind of get ready for that safety net on the other end of that. Another great tool available to folks is that there's professional skill building courses available to folks on Prevent Blindness. They have an annual summit that folks can attend, and there's a day of presentations and learnings. It's one of the other strengths is that it's very interprofessional. So there's people from various sectors that are there to advocate on behalf of better eye health. And there's schools represented there, there's private practices, policy leaders that are interested in supporting overall eye health. These are National Technical Assistance Center. I encourage folks to go to the site. They have tools that you can complete online, kind of do some basic, self-assessments on your overall knowledge of eye health, and modules that you can complete. Some are self-paced, they're free and online, and I know that there's others that are available on the Prevent Blindness site that might have a fee, but it's worth it if you're someone who is in clinical practice and is interested in improving your overall skill set, as well as depending on your community and where you're caring for patients, you may not have easy access to ophthalmologists in your community, and you might be the safety gap until you can get an appointment for someone that may not have sufficient insurance. So these are just ways to kind of help build capacity and also to better educate ourselves and our patients on overall eye health. There's also a children's vision screening certificate course that's available. I know this is probably one of your favorite ones, Dr. Brooks. So again, how to set up the vision screening environment, how to use vision screening tools, how to have proper referral protocols. That's another thing, like, the type of information that you get for a request for a specialty counsel, right? What type of information that's useful to you when you first see the patients are really important.
And it helps triage it too in terms of urgency and who it needs to go to.
Important stuff.
Yeah.
Population health information for my researchers out there that are interested in obtaining additional support and information. In some ways, I also would like to recommend that folks use this information to leverage for advocacy and resources in your community. Again, these are reports that have been vetted. There's a ton of experts around the Prevent Blindness that put this information together based on research and their expertise. And looking at vision and eye health surveillance data might, inform for research. It might inform policy strategy It can help identify scope of services that you may be lacking in your community. So, being able to tap into these resources. The other thing that I think is even more important is that Prevent Blindness has been available and in existence for how many years? Do you have any idea?
I'm not sure. So they used to be Prevent Blindness America, now they're Prevent Blindness. It's been quite a while.
Quite a while. So just know that this is an organization that's committed to preventing blindness. There's an email there and a website and a 1-800 number if folks need additional information. So I want to I think we're up to the time. I want to thank everyone for joining us. I'm hoping that this recording worked and that we'll have it available to folks later on. And thanks a lot for joining.